Good
Your
evening, sir.
slides are visible, Milton.
Okay, sir. Now it is full
Make
screen.
it full screen.
Okay. Thank you, sir.
And you are audible. You can go ahead.
Very good evening to all. So uh, our clinical pulse, our second class regarding our elbow and wrist pain, because these area are very common in our, especially in the OPD. So actually, how we actually evaluate this patient, actually how we diagnosis this type of cases, which actually I share here by few of the cases. And apart from there are some other case also. It may be differential diagnosis, or you may learn from these case from the books, as well as our different courses from like the basic course or advanced course also. So our first case.
Not audible, sir.
Milton, sounds are not audible.
Okay, sir, it's audible from here.
Video sound is not audible.
Okay, sir, I'm
You keep your microphone on.
sir. Now is it audible, sir?
No, 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 no.
Sir, another video I will try. Sir, is it audible, sir? Sir, is
Audible,
it
but very faint, very faint.
okay? Okay, sir. Okay, sir. Just a minute, sir. I'm directly actually showing my video clip rather than PPT.
That will be better. You directly show the
Sure,
video clip
sure,
rather
sure,
than in the
sure,
PPT.
sure. Sir, give me just 1 minute. Sir, now is it audible, sir?
No, 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 no. What you can do, yeah, Milton, you change your
Sir,
audio setting. You remove your microphone, you go to your
yes,
microphone
sir.
audio setting and remove your হ্যাঁ, এবার ঠিক আছে, এবার শোনা যাচ্ছে। নাও ইটস
Yes,
ওকে।
sir. Okay, sir. I'm starting from the just from the first. পরীক্ষা কেমন আসলো? আচ্ছা, ঠিক আছে। আপনি তো আমার কাছে এসে নিয়ে ব্যথাটা কোথায় আপনার? ব্যথা আমার ডান হাতে স্যার, কোনো এখানে। ডান হাতের এই জায়গায়, হ্যাঁ? কতদিন ধরে এরকম ব্যথা আপনার?
নাও ইটস অডিবল।
ওকে স্যার। ব্যথাটা কেমন? ব্যথাটা কেমন? শুধু কি ব্যথায় থাকে নাকি জ্বালা পোড়া? জ্বালা পোড়া হয়, ব্যথার সাথে সাথে জ্বালা পোড়া। আচ্ছা, অবশ হয় কিনা? অবশ্যই অবশ্যই। ভিতরে খোঁচাচ্ছে কোনো কিছু মনে হয় কি? খোঁচাচ্ছে না, জ্বালা পোড়া, সোজা করতে কষ্ট হয়। সোজা করতে কষ্ট। কোন সময় ব্যথাটা খুব বেশি মনে হয়? কোনো ভারী জিনিস গ্রহণ করলে বা একাধারে এরকম রাখলে পরে সোজা করতে গেলে যদি জগ থেকে পানি ঢালতে চান কষ্ট হয়। ভারী ব্যাগটা কোনো কিছু ওজন করে ধরে নিলে ব্যথা, ওজন করে ধরতে ব্যথাটা কমে কিভাবে আপনার? স্ট্রেচারে কমে, মানে হাতটা রেস্টে রাখলে কমে, কিন্তু তারপরে হাত সোজা করতে হবে, সোজা করতে কষ্ট। সকালবেলা ব্যথাটা কেমন? সকালবেলা এই ঘুম থেকে উঠে বেশি মনে হয়, মানে সোজা করার সময় সোজা করতে একটু কমে। ব্যথাটা হাতের কোন জায়গায় হয় আমাকে দেখান তো। স্যার এই যে এই জায়গাটাতে, একদম এই চাপ দিচ্ছি, ব্যথা এখন ব্যথা হালকা লাগে, মানে আগে লাগতো বেশি। আগে লাগতো এই যে চাপ, এই জায়গায় তো ব্যথা, এই জায়গায় ব্যথা শুরু থেকে এইখানে। এই ব্যথা তো এদিকে খুব বেশি কি আসে না? না, এইটুক পর্যন্তই থাকে। স্যার আচ্ছা আচ্ছা। We are starting examination regarding Bill's test. So first we have actually fixed this area by our one hand, especially the lateral epicondyle where the common extensor muscle insertion. So here we fix this area. After that, we just forehand just flex, then gradually extend. Gradually extend. The pain. Okay. So this is actually the Mills test. Actually here we fixed our lateral epicondyle area where actually common extensor tendon inserted, fixed by the one hand, especially the thumb region. We fixed here. After that, this is the position. Then cleans is fixed. After that, gradually we try to force position towards the surface, and he tried to actually opposite function. Here you can see it is most prominent area, and also where when actually press this area, is it painful? This is actually the Bones test. If it is painful, then lateral epicondylitis we can consider like this. Morsley test. Actually, first this is the prone position. After that, we fixed our one thumb in the lateral epicondyle area. After that, the middle finger, he tried to actually extend and actually I try to just opposite action. And is it painful? Okay, slight pain here. Okay, this is, if it is painful, then consider a lateral epicondyle or lateral epicondyle. So, what we can actually see from our history as well as our some identify the area as well as some special test. So our provisional diagnosis.
Sir, sorry for interrupting. Actually, we couldn't hear anything about history. So can you brief it, please?
Okay, sure. Actually, patient had the lateral uh, epicondyle area pain for last 1.5 year. Actually, patient came to me around 2.5 months back. Actually, that time patient have a very huge pain at this region, and after that we actually did a one ultrasound, and we got like there is a thickening of the common extensor tendon, as well as there is a hypoechoic muscle that's actually correspond with the lateral epicondylitis. So like lateral epicondylgia or so far we first we have a plan that we give some medication and some rest, but patient not improve so much. So far we plan for the actually PRP at the lateral epicondyle area, especially where actually the muscle insertion area. So this is our second session. Sorry, this was actually the third session just last week, and almost patient around 70% patient gone, pain gone almost. So actually here I want to share that how actually uh, evaluates this kind of pain, as well as how you should actually diagnosis and how can you treat. So from the history as well as where actually the pain, you can see that this is actually the lateral epicondyle area pain, as well as there is no burning. There is little bit burning, but there is no like the sensory diminish, no muscle like muscle weakness, no picking, and just especially when actually patient have a very lifting anything or heavy work, that time actually patient feel the pain. So for our provisional first diagnosis was like the lateral epicondylitis or epicondylgia. So actually here we have another some DD, differential diagnosis. Like there is the another very important ligament, radial collateral ligament. So it may be sprain, as well as the lateral ulnar collateral ligament. It may be also sprain that area, and it may mimic this type of pain with lateral epicondylitis. And also that there is the annular ligament also. It may be the either tear or sprain or any kind of changes. Brachioradialis muscle is very bulky muscle here, so it many of the time it actually myofascial pain also in this area. There are another important diagnosis like the posterior interosseous nerve entrapment, because here actually radial nerve bifurcated, and also there is chance of the posterior interosseous nerve entrapment in this area. And another is the C5 radiculopathy. So these are the actually the diagnosis, differential diagnosis. So we need to exclude these things by some special test, as well as like some of the investigations. And also another things that actually I sorry for mention here, that is any kind of inflammatory arthritis may, if there is any other joint is affected, so that time actually consider this inflammatory arthritis, but you should keep in mind. So in our clinic as well as Daradia, what actually we did, like first is the history, because history is the key of the diagnosis. More than 70 to 80% you can make your diagnosis by the good history, very good history, as well as the physical examination and some investigation. So here the physical examination, what actually we most of the time actually we don't do all of the things, but we need to actually do everything, like the inspection, palpation, range of movement, neurological examination. it may be the mimic with the C5 radiculopathy. So you should actually go for the neurological examination, some special test. And also this very important part, that is the differential diagnosis. From the other parts, we need sometimes the diagnostic block, because this diagnostic block give you the very good clue, or actually what is the pain generator you can isolate from the others structure. All we know that diagnostic block actually we use like of the local anesthesia, like lignocaine or the bupivacaine. So we give this local anesthesia, as we mentioned, it's maybe the our pain generatory structure. Suppose there is the 4-5 pain generatory structure, but we just with this like inspection, palpation, range of movement, and special test, we just conclude these or this may be the pain generator. So we give some lignocaine or the bupivacaine, or sometimes we need the both of them when actually we have a puzzle. So we need to both of them in the dual diagnostic block, at least 24 hours apart now from one to another. So if there is pain improvement more than 70 to 75%, then your pain generator may be this structure. If it less than 50%, so that time like is it near about the 50 to 70%, so sometimes it may be the dilemma, but less than 50% it may be not considered as the pain generator. Okay, so always if there is a very like few days pain, or the like there is only the metacarpophalangeus area pain, or only this area pain, but we should actually fulfill this history, because this history give you the very important clue. Here actually we have a very good history sheet. Actually we try to every patient to fulfill this type of the history sheet, as well as we can exclude the other disease. Like many of the time actually patient have a severe type of the depression, but if you are not actually exclude these things, your treatment is not complete. So pain might not gone for whole of the pain. So you should actually consider these things. And many of the time actually the fibromyalgia as well as the spondyloarthropathy or many of the other diseases may coincidence with these things. So we need to fill up this history sheet very cautiously, as well as very with your good chart. Otherwise you cannot actually diagnose this properly. After that actually we need to physical examination, like the inspection, palpation, range of movement, muscle strength, special test, and other things. And another very important, when actually you examine the one joint, the proximal and the distal joint should be also examined. Otherwise you cannot actually fulfill your exam, because many of the time actually referred pain, radicular pain, or many of the time actually the if there is the entrapment, so the proximal part is entrapped, but the distal part is actually presenting the symptoms. So you need to actually exclude, or just actually examine the both proximal as well as the distal joint also. So in inspection, so you can, palpation is very important. Joint, bones, muscle, and ligament, you can palpate with your either the superficial as well as the deep palpation. We need these things. In case of the elbow, so the first case regarding the elbow, so the flexion, extension, supination, pronation, internal and external rotation, you should actually consider these things. So here, if we consider that this is the case of the lateral epicondylitis or epicondylgia, so our main affected or main pathophysiologically, what is our main pathophysiology? Because it's actually the microtome. What is our which one is the major actually affected by this? It is actually the extensor carpi radialis brevis muscle. So above the brevis there is the extensor carpi radialis ulna, but it is the supracondylar. So supracondylar muscle not always affected. So most of the time main affected muscle is the extensor carpi radialis brevis, associated with sometimes the extensor digitorum may be associated, but sometimes extensor carpi radialis longus associated, but it is not the muscle of the common extensor tendon. But here there is some grade of changes. We can see that this is the grade 1. There is the microtrauma inside the muscle fiber, because a lot of muscle fiber and that muscles turn into the tendon. So this area where actually the turning position, that's mean the muscle converted into the tendon, that's mean the myotendinous junction, that is actually the weak point. So here, if there is the heavy weight lifting, or like we are the sedentary workers, so we have not so much associated with the heavy work. If there is the heavy weight lifting without any muscle preparation, so that times actually it causes there is the microtrauma. So this microtrauma leads to chronic disease if you not give a very good treatment, as well as not like the rest or other things. So after that, there is the angiofibroblastic hyperplasia, and there's the collagen tissue also. These actually the disorganized. So this total phenomenon actually causes, in case of the lateral epicondylitis of the like the pathophysiology of this kind of the patient. So here actually we consider like the some blood test like the CBC and some rheumatological profile, because I already mentioned there, if there is the pain associated with the other joint pain, it may be the rheumatological problem also. So you should actually consider if there is the multiple joint pains, then you should consider rheumatological profile also. So after that, there is the plain X-ray. So X-ray of the AP for the like the there is a also important joint from the lateral side. You think from the lateral side, that is the capitulum and the head of the radius. So these may be affected by the osteoarthritis also. So you can just consider these things or evaluate these things by the X-ray. But very good, as well as uh, price effective, as well as dynamic examination, you can consider by the ultrasound. So if there is any kind of pain like this, so always do the ultrasonography, because ultrasonography give you the dynamic as well as the real-time examination, and you can assess this thing either there is the inflammation or not, because all epicondylitis is not the inflammatory part, it may be the degeneration part also. So give the color Doppler. So if there is, it gives the color, so you consider as the inflammatory part. If there is no, it don't take any color, so it consider as the tendinosis, like the degeneration changes, like the chronic trauma. So for the treatment plan, maybe the changes from the inflammation to the non-inflammatory part. So MRI you can give, but if there is any injury, so as well as it's costly, it's not the dynamic, so you can give, but just consider before giving this MRI also. So after that, there is the intervention like the diagnostic block we can do for the diagnostic block. So here we can see there is the linear muscle hypoechoic area. So this is the linear tear, you can see very easily. So here it gives a huge color. So it considered as the inflammatory part at the common insertion area tendon. So what is our treatment plan? Our first treatment plan was the rest. After that, the either give the local or local heat application or the cold application, some NSAIDs, but NSAIDs should be considered for the few days, not more than 5 to 7 days, because many of the patients taking long-term NSAIDs may develop the other disease like the CKD or liver disease or any other many of the diseases. So if there is inflammation, then consider only the steroid. But remember, intrasubstance, that's mean the intratendinous, no steroid, because it causes the actually further tear, as well as it may be just disloss, or it may be just disconnection. So far, the muscle maybe the changes the whole of the thing. So if needed any steroid injection, just under or over the tendon, not inside the tendon. You can give the PRP inside the tendon as well as the out and inside. So you when actually we consider that like the tendinosis, so you just multiple time fenestration and give the PRP, because here is very tight tendon. So inside the tendon, give the PRP, very small volume is very difficult. So many of the time actually we do the multiple time fenestration, so it causes as well as the pro-inflammation. So so this inflammation actually replace, or this part actually replaced by the good quality of the tissue, same tissue that actually accelerated by the platelet rich plasma. After that, if needed the physiotherapy, or many of the time actually need rest like with the sprain. So here we show the common extensor how we actually inject these things. Here actually sound is not very important part, so we can just see the video how actually it's. First we inject the local anesthesia, only the skin part, and I have taken the platelet rich plasma just above this area. After that, then insertion by needle to the my target area, fenestration completed, and after that give this platelet rich plasma in this area. So here we see how we actually multiple time fenestration of common extensor area tendon fenestration. This is the actually the third, so almost it's near the very good. So after that we give the platelet rich plasma at this area. If we saw the actually how actually PRP and what is actually the benefit after giving the PRP. So if we evaluate the patient-related tennis elbow evaluation course, if we see the VAS course as well as the PRTE course, so at baseline before the platelet-rich plasma, the VAS scored around the 4 at the rest time. But when actually patient is activated, like the daily active life, he lived that time actually around 7, pain around 7. So here actually the pain scale around the 27, and when actually functioning it's around the 26 or 26.5. So after 4 weeks, after giving the first PRP, after 4 weeks, we saw that VAS score around half, and resting as well as the active stage, it also down. If we consider like the patient-related tennis elbow pain evaluation, it also decreased 9, and when actually the functional score, service score, that's around the 6.5. And after 90 days, it also almost VAS score in the rest time is 0. And after like the during activity or work, it's 2. So gradually it's down. If we consider from the ultrasonographic view, so we can see there is the like 0.7 millimeter thickness from this area. So after that, it actually gradually go downs. This is actually the tendinosis. Gradually tendon is repaired by the platelet rich plasma, and after like 3 months, it's near about almost the normal or near normal. So if there is any question, you can ask me, or just remember these things, and we can consider after all case dissection. So now the second actually video, I stop this sharing and তখন আপনার বয়স কত? 27 বছর। 27 বছর। আচ্ছা, আপনি আমার কাছে তো এসেছেন হচ্ছে ব্যথা নিয়ে। আপনার ব্যথাটা কোন জায়গাটাতে? তখন আপনার so here actually you know that I am Bengali. So far my patient actually talking we are discussing with language of Bangla, but there is the running commentary just below the um, video. You can also follow these things. Okay. তখন আপনার বয়স কত? 27 বছর। 27 বছর। আচ্ছা, আপনি আমার কাছে তো এসেছেন হচ্ছে ব্যথা নিয়ে। আপনার ব্যথাটা কোন জায়গাটাতে?
এই যে আমার হাতের কনুইতে ব্যথা।
কনুইতে ব্যথা।
ব্যথা
কতদিন ধরে এটা?
4 মাস যাবত। আমি তো মোটরসাইকেল চালাই, মাঝে মধ্যে পড়ে যেয়ে আঘাত পাইছি।
আঘাত পাইছেন, আচ্ছা। ব্যথাটা কি শুধু কনুইয়ের ওই জায়গায় থাকে?
না, আমার ব্যথাটা কনুই থেকে আস্তে আস্তে নিচের দিকে নামে।
একটু নিচের দিকে নামে। আঙ্গুলে তো যায়?
আঙুলে যায়।
আঙ্গুলে যায় না। আচ্ছা, ঠিক আছে। এটা কি শুধু ব্যথাই হয় নাকি তার সাথে আর কোনো কষ্ট মনে হয়?
ব্যথা হয়, জ্বালা পোড়া হয়, ছিলিক দেয়, মাঝে মাঝে অবাস হয়ে আসে, এই জায়গাটা থেকে অবাস হয়ে আসে।
কখন এটা বেশি মনে হয় আপনার?
এই কাজ করতে যে কোন কিছু ধরলে, ভারী কিছু ধরলে বা কাজ করলে,
ওইটার উপরে চাপ পড়লে তখন একটু বেশি লাগে আর কি। কখন কম মনে হয় আর কি?
রেস্টে থাকলে, কাজ না করলে।
আচ্ছা আচ্ছা। আপনার ব্যথাটা কোথায়? একদম একটু হাত দিয়ে যদি পয়েন্ট করে দেখেন।
এই জায়গাটা,
এই জায়গাটা না? আচ্ছা। এই যে উঁচা জায়গাটা আছে, যদি এখানে চাপ দিই, এখানে কোনো ব্যথা লাগে?
ওখান থেকে একটু নিচে।
নিচে।
হ্যাঁ,
এই জায়গায়।
হ্যাঁ।
দেখেন তো ঝিমঝিম অবশ্য
অনেক পেন ফিল করতেছি, ঝিনঝিন করতেছে।
দেখেন একটু বাড়ে কিনা?
হ্যাঁ, বাড়তেছে।
হ্যাঁ। কোন দিকে যাচ্ছে এখন?
উপর দিকে।
কোন দিকে? হাত দিয়ে দেখান তো দেখি।
এদিকে
এদিকে
প্রচন্ড বাড়তেছে।
আচ্ছা আচ্ছা আচ্ছা, ঠিক আছে, ওকে। Of cubital tunnel symptom by doing some special test. So first our special test is compression test. Now patient should be in sitting or standing position. After that elbow should, as well as the forearm should be in the supination, both forearm. Then after wrist should be extended, both wrist should be extended, and carry this position for up to 3 minutes. If there is any numbness, tingling, burning sensation along the area of the ulnar nerve of cubital tunnel symptom. Station of shoulder internal rotation test for cubital tunnel symptom. Patient in sitting or standing position. After that, arm should be 90 degree like this, and also it should be internally rotate, and also shoulder joint around 10 degree flexed. So after that, this wrist joint should be extend, okay, and just carry this position for further 3 to 5 seconds. After that, if there is any numbness along the area of the ulnar nerve distribution, so that causes or just correspond to the cubital tunnel symptom. Now we are demonstration regarding the cubital tunnel symptom. Special test is called as the pressure propagation test. Here actually elbow should be around 20 degree flexed, and this forearm should be in supination position. After that, one hand should be placed with index and middle finger just proximal to the middle epicondyle or just the cubital tunnel, and give the pressure over this area for 60 seconds. If there is any numbness around the distribution of the ulnar nerve that actually propagate or correspond to the cubital tunnel symptoms, So what we see that our second that this second case actually if we consider these things like from the history, actually, patient came to me with the medial epicondyle area pain, number one. Number two, patient have a history of multiple time falling in the ground because he ride motorcycle. So many of the time actually accident there. So, and this pain actually with burning, numbness and tingling, and it's like the distal end also the like paresthesia or sometimes tingling or numbing. So for our we consider that the ulnar nerve actually enter this area like the elbow area, and that time actually it is more superficial, and the when actually it is hitting the hard surface, it causes actually the severe type of the electric sensation and other things that actually many of the time we in our daily work actually we habituate this type of situation also. So but when actually it more than 3 to 4 months, so it's the pathology. So we consider that patient have there is the multiple test we did in the patient. So patient almost every special test patient have a heaviness, numbness and paresthesia. So our the provisional diagnosis was like the cubital tunnel symptom, especially in the elbow area. So here actually the ulnar nerve entrapment. So not only these things, we also considered like the other DDs also, like the lateral epicondylgia. So first, when actually palpate this area, before directly go to the in between the olecranon and the medial epicondyle, or that's mean the where the actually ulnar nerve just cross the crossing this area. But I am not focusing first in this area. First, I am focusing the medial epicondyle area. Is it painful or not? Patient give the I have no pain in this area. Just after that, just when actually tenal, just mean multiple time actually pressurize this area. It causes actually the pain as well as the numbness and the heaviness and the other paresthesia. So so far we actually differentiate from the lateral epicondylitis from this part. So another one, that is the ulnar collateral ligament. We can do the varical valgus stress, so we can just differentiate from the ulnar collateral ligament also. Then the T1 radiculopathy, because we know that this is actually the cervical 7. Then after that the cervical 8 or the T1, so it may be affected this area also. So we actually if we consider it, there is the like radiculopathy, we can just provoke it like by the Sparling test or the Valsalva maneuver, or patient may give the history of the rest like the so these actually exclude by the cubital ulnar tunnel symptoms. So after that, so every patient we need the same things: the inspection, palpation, range of movement, neurological examination, special test, and the diagnostic block. So here actually most of the time actually we know that the median nerve actually entrapment mostly at the wrist area. It is the first entrapment symptom in the upper extremity. But second entrapment symptom is mostly in the ulnar nerve entrapment at the elbow area, especially why actually it crosses the from deep to superficial, and after that it deep. So most superficial area, that is actually the bony area in between the olecranon process and the medial epicondyle, just under the fibro-osseous tunnel, when actually it crosses these things. So how actually it may affect it? So the bony fragment. So sometimes the loose bone tissue, sometimes there is the ganglion or tumor, sometimes the synovitis of the elbow joint, sometimes the regional ligamentum inflammation, some accessories muscles may interrupt these things, and sometimes the dislocation of the nerve. So this area actually the affected. So here actually the most prominent area, the medial elbow pain, and sometimes it causes the distal area also, like there is the ring finger or little finger also affected, and sometimes the intensive muscle is also affected by if there is the long term and the motor fiber are affected, so it may causes this pain, numbness, paresthesia, as well as the muscle weakness. So we know that it may develop the claw hand deformity, and as well as the first interosseous and the hypothenar, this muscle actually the um, uh, uh, mm, covered by the or innervated by the ulnar nerve. So if the long term affected, so the claw hand as well as this area may affect it. So here we can see the cross-sectional area we should consider very in our ultrasound. If it is less than 10 millimeter square, so it is normal, but more than 10 millimeter square, so it is highly sensitive to the ulnar nerve entrapment. And also we need to do the, it is the short axis view, but we need to go for also the long axis view, because where actually nerve entrapped, so the proximal and distal end may be actually the it may be the bulge, or the diameter may be the increase. So we should actually scan short as well as the long axis view. So here the almost the same things, the rest, sometimes the local application, insights. We can just give the harder dissection by the dextrose as well as with or without the steroids, sometimes the physical therapy. If there is the loose tissue, loose bones, so we should actually remove these loose bones. Okay, so here we can just how we actually hydro dissect. Actually this patient still now we are not doing the hydro dissect, because hopefully this patient improve with the medicine, because the diameter of the ulnar nerve is not so high, and we just give him the just try to very cautiously do when actually he drive the motorcycle. Just we give the some advice. If not improve, then we go for the second intervention. Here actually we saw is another case. So we can this is actually the ulnar nerve. You can see, and it ulnar nerve actually we separate from the surrounding structure by the above and the lower part by just separating by giving the dextrose with dexamethasone, just separate from the another tissues. Okay. Now our third case. So কেমন আছেন? ভালো আছি। আপনার নাম হচ্ছে রকিব, না? বয়স কত আপনার? বয়স 28 বছর। 28 বছর। কেমন আছেন? আসসালামু আলাইকুম। ওয়ালাইকুম আসসালাম। কেমন আছেন? ভালো আছি। আপনার নাম হচ্ছে রকিব। Sound is clear?
Yes.
আসসালামু আলাইকুম। ওয়ালাইকুম আসসালাম। কেমন আছেন? ভালো আছি। আপনার নাম হচ্ছে রকিব, না? বয়স কত আপনার? বয়স 28 বছর। 28 বছর। আচ্ছা, কি সমস্যা নিয়ে এসেছেন আমার কাছে?
মানে হাতের ব্যথা।
কোন জায়গায় ব্যথা?
এখানে ব্যথা, এখান থেকে এই আঙ্গুলের দিকে, এদিকে এই আঙ্গুল আর এই তিনটা আঙ্গুলে ব্যথা।
কতদিন হলো এটা?
এটা অ্যারাউন্ড 6 মাসের মধ্যে হয়েছে।
6 মাস। এই শুধু তিনটা আঙ্গুলই আছে? বেশিরভাগ
এই তিনটা আঙ্গুলে।
আচ্ছা আচ্ছা। ব্যথা আছে নাকি সাথে আর কোনো কিছু মনে হয়?
ব্যথাতে ঝিনঝিন অবশ অবশ আসে।
কোন জায়গাটা অবশ অবশ?
এই পুরোটা জুড়ে একবার আঙ্গুলের মাথা।
কখন এটা বেশি হয়?
এটা আমি যে কোনো কিছু লিখতে যাই বা হাত পাকা করে এরকম কোনো কাজ করতে যাই, তখন আমার বেশি হয়।
বেশি হয়। এমনি মানে ভালো থাকেন বা ব্যথা দেখা যায় না?
যদি কোনো কাজ করি এমনি হাত স্বাভাবিক করে রেস্টে থাকতে পারে ঠিকঠাক।
Some special test regarding our carpal tunnel symptoms. So we should actually propagate the median nerve at the wrist area by the Fresnel test. How actually we are doing these things? দুইটা হাতকে একসাথে এরকম করুন। Then gradually it's going up and hold for at least 1 minute. So here actually when actually you maximum flexed your wrist joint, the most superficial structure, that's mean the median nerve just under the common flexure retinaculum, just it's just compressed. So when actually it's pathological, so this compression, that's mean the when actually we give the extra like this type of the pressure towards the median nerve with the flexion, so it causes actually the compression. So one compression from the flexed retinaculum and another compression that we created by this extension. So if it is painful after just one continuation, if there is any pain along the thumb, ring finger and the middle finger, if this is actually pain, numbness or tingling in this area, that actually correspond to the carpal tunnel symptoms at the wrist area. কোন ঝিমঝিম অবশ্যের মতো হচ্ছে কি একটু আগে থেকে একটু বাড়ছে? Now we go for another one special test for the median nerve regarding the carpal tunnel symptoms. Here should actually hand should be in the supination, and after that we should actually propagate the median nerve at the wrist area where actually it crosses the flexure retinaculum area. So here actually we tapping this nerve by our one hand. This is called actually the Tinel sign or Tinel test. So if it causes multiple time, it should be tapping multiple time. It causes the pain, numbness along this thumb, index and the middle finger. So then we consider as the Tinel sign positive. That's mean the carpal tunnel symptom positive. One special test, so it's called the carpal compression test. The forearm should be in the supination, and here just press over the thenar and hypothenar muscle by the examiner by the two thumb and press this for 30 seconds. If numbness, paresthesia along the median nerve, that's mean these three finger is affected, or numbness or any paresthesia provoked by this compression. So then we consider as the carpal tunnel symptom. So in our third case, so what actually we saw that patient have a pain in the wrist area, and we first there is some clue from the character of the pain. So from if you analyze the character, there is the hyposthesia, there is the burning, there is the some numbness and tingling. So our thinking it may be the nerve, may be the affected. So from these kind of patient, and especially in the like the lateral three finger affected, so it's very clean cut of the carpal tunnel symptom. So our professional diagnosis was like the carpal tunnel symptom. So some DD. So you know that there's the first compartment of the extensor area. So it may be affected by actually the decurvence we consider as the decurvence. So sometimes this pain also mimic this hand also. There's the another is the this is the first base of the metacarpal bone, also degeneration, so it may be the osteoarthritic change also. So another is the peripheral neuropathy. If patient have the diabetic for the long time, so it may mimic with the numbness, it may be mimic with the paresthesia and burning sensation also. And C6 is very because all over all the cervical radiculopathy, C6 and C7 is the very common. So C6 radiculopathy just mimic with these two fingers. So you should consider, and as well as the examine the cervical area, and you should go for the Sparling test, relief sign, and the Valsalva. If there is the positive, so you consider the C6 also. Okay. Sometimes the proper symptoms may mimic with the this of the problem. So little bit of the little bit of the carpal tunnel symptom. We just know about these things. This is the carpal tunnel, actually the osteofibrosis canal situated in the volar wrist. Why osteo? Because it just over the carpal bone. So you can see this is the carpal. So over the carpal bone, this is the one part, and the another part that is actually the fibrosed. That's been the tough ligament type of things. So in between there is the tena structure actually arranged, and it passes in between two structures. So it like the tunnel. So here it is the compact. We know that the distal end and the proximal end, there is the muscle, but here is the compact, and this compact area, if multiple time like the friction, if there is the any either any of the tendon is enlarged in diameter or enlarged in flexor retinaculum, so it causes the pressure over the median nerve. So we saw that there is the important structure just under it. There is the median nerve, and another 9 structure that is from the one is the flexor pollicis longus, and another 4 tendon. It's from the flexor digitorum superficialis and the profundus. So from this nerve actually, when actually just compressed by the another structure, it causes actually the pain. And another very important things, flexor retinaculum, actually most of the time we actually saw the proximal end, but distal end also very important. With the proximal end, that is the convex type of the arrangement, because we know that the retinaculum around 2 to 3 4 centimeter around diameter. So the proximal and the distal end, it should be always, you should actually scan both of the area. That's been the whole length you should actually screen these things. And most commonly that we found, if there is any anatomical variant like the bifid median nerve, or sometimes the there is the abundant artery, or there is any like the flexor retinaculum is the thick. Otherwise the patient obesity, pregnancy, diabetics, any thyroid problem, or any rheumatological problem, it just risk factor for the carpal tunnel syndrome. So here actually we saw that there is these 3 finger, mainly the thumb, index, and the middle finger, and the side of the ring finger. But this mainly these 3 finger, as well as these area actually affected. And patient actually sometimes cannot perform like the buttoning of the shirt, or using cannot use the zipper. And the morning time, even the night time may it increase the pain. So other causes like already we discussed, like the diabetes, rheumatoid arthritis, obesity, pregnancy. If there is the infertility, many of the time actually they give the huge type of the huge like hormones from the outside. It causes actually the rest of the life, the flexure. I got many of the patients like thickening of the retinaculum, and it causes the compression. Very recently, one gynecologist came to me. He has a history of like this type of the problem, and taken like hormone for ovulation and for infertility. But very recently, is a very severe type of the pain. We actually just hydrodissect from the retinaculum. In our first time, it almost 90% got, but after 1 year later, then when actually the second, around 1 month back, now pain around 50 to 60% remove, but not fully. So for if it is the anatomical variation is more and the thickening is more, and patient, because patient have a very obese patient, more than 100 cases, so that time actually we sometimes consider more than the intervention, so sometimes we need the surgery also. So actually the very good history give the very good diagnosis. So gout, menopause, like psoriatic arthritis or any ganglion cyst, it may actually decrease the osteofibrotic tunnel area, so it causes the compression over the median nerve. So we can evaluate. We already share here the Fresnel test, Tinel test, and the compression test, and sometimes the hand evaluation, elevation test also. We consider this test for the diagnosis. And the history examination, ultrasonography is very, very good. You can, because there is the cross-sectional area, we can consider for the cross-sectional area. If the cross-sectional area, there's the some measurement. If the cross-sectional area more than the 10, then we consider for the CTS. More than the 15, we can consider the severe CTS. Many of the time we actually go for the NCV, because we need to exclude from the other disease, so we need to the NCV. And many not usually do in our daily practice MRI, but may need. So you can see here very big hypoechoic and the honeycomb appearance of the pattern, and also there is the hypoechoic. So it's usually the in case of the normal nerve, it's not like this. Because here is the edema we can see there. So you can see this is the normal nerve. Here is the entrapped, the proximal and the distal part, that is actually the diameter is very good. But here where actually the entrapped, this area actually just compressed by the outer structure, and nerve is compressed. So so short axis as well as the long axis, so both of the view you need to actually consider. So less than 10 it is normal, so more than 10 it's the considered as the CTS. If more than 15 is the severe compression. So almost the same treatment, the rest at the provocative, there is the provocation, precipitation history, so need to actually remove these things. Then rest exercise, the exercise for the flexibility and strengthening of the surrounding muscle, flexor retinaculum, and the rest of the nerve. And sometimes we consider as the steroid injection. If there is also we consider for the PRP or dextrose also. So here actually usually we enter from the like medial side, from the ulnar side. Why? Because the radial side, there is the very important artery. So if you puncture this artery, or sometimes you injury this artery, so it causes the pain. And also there is the superficial radial nerve, there is the sensory nerve. So if there is a compression this nerve, or hitting this nerve by the needle, or injury this nerve, so it also causes the like superficial radial nerve symptoms. So these area actually affected by this. Sometimes we are wearing the wrist, so it may cause also the compression or the outer side. There is if there is the very adherent or tightly adherent wrist watch, so it causes injury to the superficial radial nerve. So better to go from the ulnar side. So you can see these things. You can use the gel standoff technique if you avoid injury of some of the structure, if there is no space for the in the needle entry, so you can use for the gel standoff technique also. And the superficial, this is actually the retinaculum. So this retinaculum and this is the median nerve. So in between, your needle should be placed here, and also just under the median nerve. You also dissect from this area. So here actually we saw this video. Just under nerve, we come and give the dextrose, and above the nerve, just enter, and after that we just hydrodissect from the surrounding structure. And now you can see very good structure. You can see the median nerve from the outside. It is in the short axis, and you can also go for the long axis also. So you can see this is actually the this is the transverse ligament. Just under the transverse ligament and over the median nerve, you just give your dextrose, so far it's just separate from the surrounding structure. Very you can see very nicely separated from the structure. Now if you give the PRP, actually role of PRP is actually remyelination, so axonal regeneration, and the agonesis of the peripheral angiogenesis of the injury peripheral. If there is any injury to the peripheral nerve, so angiogenesis is very good for the blood supplies. When actually there is the degeneration, there is some vascular supply is diminished. So if there is the angiogenesis, just it improve of the remyelination, and the quality of blood supply is very good. And you can also give the dextrose, because just inhibition of the transient receptor potential, vanillin receptor 1, actually these receptor actually just trigger and provocate the the inflammatory these things. So you can consider also the dextrose, and it is the hypertonic solution. So when actually you give the hypertonic solution, so it causes the nerve when actually nerve is swelling, so inside the nerve there is the fluid. So when actually give the dextrose, the extra water that actually is situated in the inside of the nerve, it actually cross the cell membrane, and the nerve gradually in the normal stage. That's when actually the nerve thickness increasing, like there is the nerve thickness around more than 10, so like it is 12 or 13. So if give the dextrose, it gradually come to the normal diameter. So far we can give steroid as well as PRP as well as the dextrose, and recently we give mostly the dextrose or the platelet-rich plasmin. So thank you. So I have just shared the 3 cases, 2 from the elbow and 1 from the wrist. If there is any question, or if there is any dilemma, or if any kind of question, just ask me.
Hi, Milton, sir. May I ask, you were saying regarding the hypertonic dextrose on inhibiting the valinoid receptor, but you are talking about that is for the tendinosis, tendinopathy treatment, or you are talking about hydrodissection? Thank you.
See, hydrodissection, we doing the hydrodissection by the dextrose. So so here we have a actually one is the separation from the structure, and another one when actually give the some hypertonic saline in around the nerve area, so it causes the actually the just extra fluid just happen in the just inside in the nerve, it causes the just come out from the nerve. So the swelling nerve it gradually the come to the normal structure. So hydrodissection is the one part, because without hydrodissection, you cannot give the saline in and around the nerve. So first is hydrodissection, that actually hydrodissect from the other structure, and the another one things when you can also hydrodissect by the normal saline also, that's been the normal saline like the 0.9% normal saline. But here the hypertonic saline gives the another one benefit, because it not only hydrodissect, it also actually decrease the edema of the nerve tissue.
So
I think
your suggestion of the concentration that should be used
Oh
for the
yes,
hypertonic.
concentration it's in the around the nerve area. We actually use the around the 7.5. That's been the less than 10%. So actually, like how actually we I make these things. Like you have taken the 25% dextrose. That is available in the in your like pharmacy. So 25% dextrose. So first you give the 25% dextrose and make it the 3 ml, like 1 ml make it the 3 ml, so it is 3 time dilution. So if you consider it's around the 8%, so another 1 cc I take the dexamethasone, so it's total so these around the 7.5 to near 8%. So this actually concentration is very good for the nerve.
Milton, can I add on to this?
Yeah, sure.
Okay. I think the gentleman question is regarding the concentration of dextrose that will be using. For hydrodissection, we can use only 5% dextrose is good enough, sir. Okay. But if we are going for dextrose prolotherapy for tendinosis, then we usually go for this 12.5 to 15% of dextrose. So just for hydrodissection, 5% dextrose or normal saline is good enough. But for tendinosis to cause neovascularization and prolotherapy, we are using hypertonic like 12.5 to 15%, sir. So did I answer your question, sir?
Yeah, I agree with Sherry, sir. But however, according to Milton, sir, his underlying pathophysiology is to reduce the edema. Besides using the dexamethasone effect, they are trying to get a hypertonic to create the osmosis feature. So if you are thinking of that benefit, then 5% wouldn't help. Then you need a higher concentration. But of course, higher concentration might actually be causative to the surrounding tissue or more painful if we were to do a hydrodissection over the kappa.
For hydrodissection, simply 5% dextrose or a normal saline will have an excellent effect. We need not go for, because it's a dextrose, it will be absorbed by the tissue very nicely. It contains sugar, so it will be absorbed by the tissue very nicely. But if you definitely, if you are going for a tendinosis, then we usually hypertonic solution to create apoptosis and start inflammation, and then again healing cascade. So slightly clinical practice may change, but generally what we do for hydrodissection is normally no need to add dextrose, just 5%, no need to add steroid, 5% dextrose or normal saline, simple. But for tendinosis, go for higher concentration, 12.5 or 15%.
Excuse me, sir. Sir, this normal saline we use is 0.9% that we use normally.
Yes,
It has to be hypertonic.
No, just 9%. Hypertonic saline will cause severe pain, and we are using just for hydrodissection, separation of plane, and that basically entraps the nerve or tissue. So normal saline, 0.9% normal saline would have a nice effect, Bindu, ma'am. Not hypertonic solution. Hypertonic solution, normal saline will cause severe pain. And our aim is just to release the entrapment, not for any apoptosis, start apoptosis or inflammation. So just 0.9% normal saline or 5% dextrose for hydrodissection. Okay. Any other question, my students? Milton has very nicely. Last time in my class, my laptop was was not working nicely, so I couldn't present. But today Milton did an excellent job regarding 3 different varieties of case presentation, and the cases that he presented is most commonly common in the pain clinic, like lateral epicondylitis or even carpal tunnel. These are very much common in day-to-day practice. So thank you, Milton. Excellent job in case presentation as well as PowerPoint presentation. Any questions, Arpana? Any questions?
Sir,
Yeah,
if
Arpana.
may I ask, I don't know. I mean, can we discuss something about decurviance because it is in the similar?
Of course, Decoverven. It is very much
Yeah.
common. So what do you
Yes,
want to
and
ask?
sir, I mean, what are the treatment modalities and just how should we go about it? Like with carpal tunnel syndrome and decurviance because
Okay.
it's a thumb pain only in
Okay.
decurviance.
Decurvian mainly is like always, if depending upon the severity of pain, we usually go for conservative management, like non-steroidal anti-inflammatory drug. And splint is more a thumb. There is a splint called thumb spica splint. So it basically immobilizes your thumb, and
Yes.
it prevents the movement of the thumb. So that would be your first choice, and
Okay.
NSAID and rest to the tendon which is inflamed. So even if the conservative management is not working, then you simply go to the compartment number 1, see the fluid around the tendon, mainly
Yes.
abductor pollicis longus and extensor
Yeah.
pollicis brevis. And if you can, just give about 20 milligram of methylprednisolone along with 1% of lignocaine, 2 ml of drug will have a very nice result. And after injection, also give rest for 2 or 3 days and painkiller for 2 or 3 days. That would take care of the problem, decuvarin. Okay, so
Right.
manage conservatively initially with rest, and we can immobilize the thumb using thumb spica cast or splint,
Okay.
and give NSAID. If it's not relieving, then use ultrasound, get to the first compartment and inject about 20 mg of methylprednisolone along with lignocaine.
Around the tendon.
Around the tendon and within the tendon sheet and tendon there will be fluid. If you see in ultrasound, it will be like a car tire shape, like in the middle there will be tendon, and it will be surrounded by an echoic fluid, and at that space you have to deposit drug. Okay.
Okay, sir. Yes.
So, and coming to your second question, carpal tunnel syndrome. Carpal tunnel syndrome, it has a very good result. Previously, they would go for the release of surgical release of this flexor retinaculum, but nowadays we are doing hydrodissection of the nerve. So what we are doing is we are basically seeing the carpal tunnel in a short axis, and around the nerve we are either giving 5% dextrose or 1% lignocaine with 20 to 40 milligram of methylprednisolone, and basically we inject the drug around the nerve under the guidance of ultrasound.
Okay, sir. Thank you so much.
Okay. People are nowadays not using steroid. They are going for hydrodissection with 5% dextrose. There are lots of paper published with that, and they have said that it has an excellent result. But I would prefer for the steroid and lignocaine.
Excuse me, sir.
Yeah.
Just now, Sir Milton mentioned about proximal and so distal carpal tunnel syndrome.
Yeah.
Is there any clinically, how do we differentiate them, and any implications clinically?
Okay. So proximal carpal tunnel, and this carpal tunnel is about length is about 2 centimeter. Okay, from proximal to distal. So proximal carpal tunnel starts with scaphoid and pisiform. One side in the radial side scaphoid, and ulnar side pisiform. So if you scan at that area, that would be a proximal carpal tunnel. But if you come distally, come down about 1 to 1.5 centimeter, and then there will be the bone which will see looks to be try to catch a trapezoid, and pisiform will be at the level of trapezoid, and pisiform will be the level of the distal carpal tunnel. And we are basically injecting drug within the between proximal and distal carpal tunnel, not above not proximal to the proximal carpal tunnel. We are injecting drug at the proximal carpal tunnel or just distal to the proximal carpal tunnel, not more proximal to the proximal carpal tunnel. So it basically it is a site for injection. We have to be within the proximal and distal carpal tunnel or at the level of proximal carpal tunnel for hydro dissection of the median nerve.
Okay, thank you, sir.
And how to recognize? Just see the bone. If it's at the level of scaphoid and pisiform, it's a proximal carpal tunnel. And if you just slide your probe more distally, then trapezoid and pisiform will be the level of the distal carpal tunnel.
Also the proximal is the convex and the distal part also almost the flat. So the bony landmark and the this character of the or the shape of the flexor retinaculum. So these two helps actually either it's entrapment in the proximal or distal. But the not only short axis but also need the long axis, because without long axis scanning, you cannot actually identify either it is entrap or not.
So can we do these procedures blindly also, or the landmark technique, or all the only USG guided, sir?
Nowadays we actually not doing
Nowadays, please do under guidance of ultrasound, not blindly, okay? So blindly is not recommended at all. Under vision, under guidance is the way to do it. That is the difference between the pain physician and other like subspecialty. We have the skill of ultrasound, especially musculoskeletal ultrasound, and we have to use it for the benefit of the patient. I never do blindly.
Okay.
Sir, that's 5% dextrose.
Yeah, 5% dextrose for hydrodissection.
And gives pain relief immediately, sir, or we should do it with local anesthetic?
Just a basic rule is if we are just going for hydrodissection, then 5% dextrose or normal saline. But if we are causing prolotherapy, you are going for prolotherapy, then the concentration has to be increased like 12.5 or 15%. That is the basic rule of thumb. So anywhere.
What about mixing locally?
We can mix
Should we mix locally, sir?
Yeah. If you normally the dextrose will come in 25%. We can decrease the concentration if you are going for prolotherapy by mixing with 1-2% lignocaine, of course. But normally 5% dextrose, we are not mixing anything, because if we mix anything, the dilution will be less than 5%. So normally we do local anesthesia and to the skin with a very small needle, 26 gauge needle, and then proceed with hydrodissection with 5% dextrose.
Okay.
So how frequent do we have to repeat this procedure? Do we have to repeat it every week or things like that?
Normally we see the patient in follow-up after 3 weeks to for 1 month. Then depending upon the progress of the patient, we might go for repetition of the for the injection. Sometimes one session of injection can give an excellent result, whereas in some patient, if it is a severe carpal tunnel, then we may have to repeat for 2 or 3 times. But we usually wait for the 2 to 3 weeks, see the response of the patient, and then repetition is done like that. It's not that to all patients it has to be repeated, but sometimes they may require repetition depending upon the progress in the follow-up, sir.
Series have joined.
Yes, sir. Okay, sir.
So I was just listening here these things. So our experience at Daradia is, when we are using steroid, then there's more chance of the repeating it. Recurrence is much higher. When we are using 5% dextrose, initially, we are using 5% steroid for a long time. If you are telling me I am practicing almost 25-30 years, so almost 20 years or more than 20 years, I have practiced the steroid injection. And steroid injection gives good result, but the problem is the chances of recurrence was there in at least 20 to 30% patients was having the recurrence. You have to repeat the steroid or you have to send it to the surgeon for the operation. But when you have started dextrose injection, the chances of repeating it extremely rare, extremely. I might be telling you now after I have started dextrose injection since the last 3-4 years, only 1 or 2 cases out of several hundred cases I have to repeat. So chances of repetition with the dextrose injection, initially you might be thinking a little bit skeptical. It is a new type of treatment, whether you have to accept how much you have to repeat. it is the response is not as dramatic as steroid. Steroid, normally the response is very dramatic. Within 1 or 2 days, symptoms starts relieving. But in dextrose, it is less dramatic. It normally, the improvement starts gradually. And the peak onset normally 3 to 7 days. After that, you will be gradually getting the improvement. And what series told, after 3-4 weeks, we need to decide whether we have to go for. I normally ask the patient to come something around 3 to 4 weeks for the follow-up visit, and by that time we decide how much is the diameter of the median nerve is reduced, or the any other nerve entrapment. The treatment is same, and then we decide what is my observation is the most of the time, maybe more than 90% situation, there is no need of giving the second injection. Dextrose is a magic, 5% dextrose. And this is not prolotherapy. Prolotherapy, when you use it, when it is a concentrated, so that time we are using basically dextrose as a pro-inflammatory substance, and there we can call it as a proliferant. But when we are using 5% dextrose to hydrodissection of the nerve, so here we are not using dextrose as a proliferant. It is a physiological solution.
So then what do you think about using using dextrose plus with steroid? So you have a dramatic and prolonged effect.
The problem, if you are mixing with the steroid, then your volume of the drug will be reduced, because in a tunnel, if you are increasing giving the steroid will not be immediately absorbed. So what will happen? You cannot give a larger volume. So now dextrose, one of the reason why only dextrose gives the better result than the steroid, that you can give a larger volume. The larger volume is beneficial. How? Because one of the mechanism of the dextrose is the vasa nervorum will be basically the decompressed. It will be relieved, and that depends on the volume around the nerve. So what you are telling, it needs study to tell that whether the dextrose plus steroid is a better or give immediate and the prolonged effect. I don't have any experience, but very rarely, 1 or 2 cases only I have mixed. Majority cases I normally give only dextrose or only steroid. Very rarely 1 or 2 cases I have mixed. But again, if you are telling that, okay, this mixture is better than the dextrose or steroid alone, then we have to have some good study to tell that whether this is really better or not.
So will you do a fenestration of the flexor retinaculum?
Yes, we always do the fenestration. So what we do, that you can go to our YouTube channel where some of the videos are there. So we normally put 2 needles, one in the short axis, one in the long axis. The long axis, superficial to the nerve, we do the fenestration of the flexor retinaculum. And short axis, we give both above the nerve and below the nerve. You know why short axis is needed? Because in the long axis, you cannot go below the nerve. So normally, if you are giving the dextrose injection both above the nerve and below the nerve, then your result is better, because that means you will be completely dissecting out the nerve with the dextrose injection. That gives better results. So that's why fenestration is done by the long axis needle, and short axis needle you are doing the hydrodissection with the dextrose. And these videos are there in your YouTube channel. So please go there and see how we are doing it.
Thank you, sir.
Then, sir, wanted to ask 2 questions. One is regarding for supinator syndrome and lateral epicondylalgia, the differentiation, and second would be, if let's say for Guyon's canal syndrome, is it important clinically for me to know where is the site of entrapment, whether around the hamate or after that? Because since we are going to give a hydrodissection, it's a fluid if you still pass down distal and proximal. And if let's say is important, then should we actually ask patient to go for certain MRI to see where is the exact compression site, even for ulnar nerve at the cubital tunnel, because certain features we might not be able to see through ultrasound.
What you are telling is absolutely right. Sometimes, very recently we have seen one patient. He was having the pain along the ulnar nerve distribution. So when we saw the nerve both as the cubital tunnel, as the Gann canal, and we followed the nerve throughout the forearm, so nerve was looking swollen and everywhere, and it is very difficult to decide exactly where is the entrapment. So sometimes this can happen, that again, what exactly. that entrapment. And double cross syndrome is, that sometimes the nerve is getting entrapped at the 2-3 regions together. So if you are having the dilemma, then it is always, because dextrose injection is very, there is no upper limit of the volume. If you are having any dilemmas, you give both the sessions, both areas. Like recently, what we did in this patient, we have given the dextrose injections both at the cubital tunnel as well as in the Guyon's canal, and also we have given because entire nerve was thickened, and patient was seen by the neurologist. EMG, NCD was done, everything was coming normal, but ultrasound wise, patient was having the thickened nerve, and as well as the patient's pain and the tingling sensation was typically 1.5 finger. So we have done there. So what you told that, okay, to understand the exact area where it has been compressed, sometimes it is difficult. So ultrasound might be helping you if you are seeing that, okay, proximal to that there is no swelling, distal to that there is no swelling, whether there is notch sign or that there is any compression. This can help, but many times this may not be helpful. And MRI also might not be helpful. Like in this case, MRI was done and that was not commenting anything about exactly where was the compression. So this can happen. And in this situation, as I told you, the beauty of the dextrose is that there is no upper limit of the drug dose. And if you are feeling the possible areas, and you can go ahead. Another thing, clinically, it might be helpful is to see the the tinel sign. You can just percussion on the nerve, entire nerve path, and you can see exactly where the patient is having the more symptomatic on the percussions. So that might be again helpful, but many times it is really difficult to understand exactly where is the compression. And as I told you, double cross syndrome, that where the nerve might be compressed at not one side, may be compressed at 2-3 times, 2-3 sides. That is also a possibility. Basically, nerve entrapment, peripheral nerve entrapment is a new subject. And many of the things is still not nicely understood. That, as I told you, dextrose injection is giving miracle. But again, exact mechanism is still debated. Still now, the most acceptable mechanism is the vasonervorum decompression. But there might be some other also, like TRPV1 receptor, all other things. Many, the hypotheses are there, because we really don't know exactly how it works. So peripheral nerve entrapment is really a new subject. Earlier, we always used to think spine is the fault. I can remember when 20 years back, I used to take the class. We always used to tell that, okay, all this nerves entrapment is because of the spine only. People was textbook, all the books was like that only. Gradually, peripheral nerve entrapment, role of muscles, where the nerve is piercing, so muscle spasms, all those things are coming out. Dextrose injection is also similarly a very new one. Only, a few years it is in the field. And already meta-analysis are there with the dextrose, which is stating that the dextrose is better than the other therapy in the carpal tunnel. And very soon the other papers are going to come. But as a whole, the peripheral nerve entrapment is new. So many things is yet to understand. But dextrose is really a miracle. And most important part is dextrose has almost no side effects.
Sir, any specific post-procedure advice we are supposed to give to the patient?
As such, nothing, only paracetamol and a little bit of cold compression just post-injection site, but not much cold, because much of cold what can it do? It can do the vasospasm. Again, the nerve supplying the vessel supplying the nerve might be again going to the spasm, which might be increasing the nerve damage again. So basically, post-procedure, nothing. Just give simple paracetamol, do the normal activity, little bit of rest for 1 or 2 days, and after that, normal activities. So no specific the post-procedure advice in these situations. Just advise the patient to do the normal activities. No active exercise in the initial 1 week. Active exercise after the injection pain is reduced, then we can go advise them for the active exercise. Before that, no exercise, just normal daily life activities, that's all.
So can we give dextrose in tennis elbow also, or just a steroid?
Tennis elbow, again, we have to understand the pathology. Tennis elbow is not really the nerve entrapment. I was telling the 5% dextrose injection in the nerve entrapment works like miracle. And the hypertonic dextrose can be used as a hypertonic dextrose was used as a proliferant therapy, like in the osteoarthritis knee and all those things. So now for coming to tennis elbow, it is a degenerative condition. It is a tendinosis of the common extensor tendon or golfer's elbow common flexor tendons. So here the most important thing is your fenestration. If you are doing the puncturing the needle with the needle, the tendon, then what will happen? There will be increased vascularity, which might be repairing the things. And there you can add the PRP as well. Even there are some posts, I can remember almost 5 years back, as a reviewer, I was getting a request from a journal where there was the good article, the meta-analysis of steroid versus just simple blood. There are lots of paper in there. Just draw the patient's autologous blood and you just give injection of this blood into the tendon or around the tendon. That also gives very good result. So normally these are the things which can be done. Steroid is nowadays obsolete around the tendon, this thing, but still many people give steroid in the tennis elbow also. But I'll be telling you to do the fenestration and the PRP injection. That gives better result. Whether the dextrose is also helpful or not much studies in favor of the dextrose. But PRP and blood and steroid, these are the three things, and fenestrations, four things I should say, that these are having the better evidences than any other things.
So blood, autologous blood, 1 ml only, sir? Like the dose, like we give a steroid,
yes.
1 ml.
1 to 1 ml blood, no steroid. I just fenestrate and give the patient's own blood. That's all.
Okay.
And you can search the PubMed. You'll be getting lots of literature, published literature on favor of the autologous blood only. Not doing anything, just put a little bit of 1 drop of heparin as an anticoagulant, and you just take the patient's own blood around 2 cc, 1.1 to 1.5 cc, you just give around the tendon after doing the fenestration. That is also a very good procedure for the fenestration. Though I personally don't do any blood, so I cannot tell my experience. I have done several cases with the PRP that I can tell is a good result, but blood also is there mentioned in the literature.
How many doses of PRP start in case of tennis elbow?
Pardon, can you repeat?
How many sittings of PRP in case of tennis elbow, sir?
The kind of things what I told about the carpal tunnel, majority sessions, only 1 sessions with the PRP and fenestration is enough. If you're doing the nice fenestration and the PRP, 1 session is enough. If you're giving steroid, there is more chances of recurrence. And sometimes you might need to repeat. It is not that always 1 session will be always effective. I can still remember one of the badminton player we did once, but result was not that optimum. But apart from 1 or 2 cases, majority of my cases, I have seen that the 1 session is enough.
Thank you, sir.
So what's the rationale of using PRP in carpal tunnel syndrome since it is not a degenerative disease?
Carpal tunnel PRP is not that, some papers are there. But again, what is my belief that whatever you are giving some volume there around the nerve is going to do the miracle, because you are basically releasing the vasonervorum there. So as I told, PRP in the tennis elbow is what I told. PRP in the carpal tunnel I have not told. But still there are certain papers which are in favor of the PRP also in the carpal tunnel, which is telling good results. But what is the mechanism of action of the PRP? As you raised the question, I also fully agree with that what is the rationale of giving the PRP, because here we are not dealing with a degenerative disease. Here we are dealing with a nerve compression. So there the compression means releasing decompression of the vasonervorum is the most important part, and that can be done with any fluid. If you are giving any fluid around the nerve, that is going to do the decompression of the vasonervorum. So I believe if the result is there because of the PRP, might be because of the decompression of the vasonervorum. But if you are looking about all the literatures in the carpal tunnel, recent literatures, meta-analysis, all are in favor of the dextrose injection. You can just search PubMed and see what are the most recent trend of treatment of the carpal tunnel. You'll see that it is a 5% dextrose injection in the nerve along with the fenestration of the flexor retiniculum. That has to be done.
Thank you, sir.
Sir, if a patient presents with multiple pathologies like C6 radiculopathy along with carpal tunnel, should we go for the intervention?
You see, always, it is not that we will be always jumping for the interventions. There is always, we have to believe with the body's own, healing mechanism. Majority of the conditions are healed by the body's own healing mechanism. Like if you're talking about the prolapse disc, what is the natural sequence of a prolapse disc? Is the patient is going to get the paralyzed? Answer is no. More than 80% situations, the subsequent MRI has been taken and seen that the disc prolapse, excluded nuclear material is engulfed by the body's phagocytic mechanism, and the disc is repaired by its own healing mechanism. So the same kind of things can happen in almost all pathologies. So because these pathologies are not life-threatening, so we can wait for some time and we can allow body's own healing mechanism to see how much it is, healing, how much it is doing. And in our role in these positions will be to relieve the pain and treat conservative management, little bit of rehabilitations and wait. But if we see that the pain is too much, your conservative management is not working, then of course you should be intervening. So just not the radicular pain, not just the nerve pain, will be always jumping for the interventions. We should be always, there is always a role of conservative management and waiting for the body's own healing mechanism. If not, or if the pain is more, or if the patient not responding to the conservative management, still patient is having a lot of pain, definitely we can go for the interventions. Now, interventions for the evidence-based. Always intervention, you have to remember, I always tell this thing, every class I always tell these things that, okay, don't do anything by looking about 1 or 2 published literature. You have to follow the recommendations by some of the societies' guidelines or at least some meta-analysis. Otherwise, you just saw one published literature or one RCT, you should not be jumping to do that procedure. Now, based on published literature, what you told, somebody is having the C6 radicular pain or radiculopathy, the best treatment for this intervention is your steroid injection in the foramen, either epidural injections, or nowadays we can also do the ultrasound guided selective C6 nerve root injection. Soluble steroid, you can go for that, or you can go with the epidural steroid injection. This is for the C6 root pain, and for the the peripheral nerve entrapment is the dextrose. So now both can be combined, or it can be combined with separate different sessions depending on your assessment about which is giving more pain. If you are feeling the whole of the hand is having a lot of pain, or the relief sign is positive, your the Jackson compression test is positive, Sparling sign is positive, then you should be targeting more about the nerve root rather than the peripheral part of the things. And if you feel that these are not that positive, then you have to rely thinking that, okay, the peripheral part is more important, then you may be doing it later on. First you can go for the dextrose hydrodissection of the nerve. So all the decisions would be there depending on your clinical findings.
Thank you, sir.
Okay, so let us say good night for today and waiting for the next one. So this, the clinical part, case discussion is very important, and I hope all of you are enjoying these discussions. And I'll be telling all of you to be an active part of it. Ask us questions, think yourself, think it rationally, and read it and ask us questions. We can have a very friendly discussions, and we can learn from you as well. So this is a basically learning session for all of us. So thank you very much and good night for today.